order. I mean, it must be said. I mean, number two, Chair, and very important, you cannot discriminate. If you read the Fair Administrative Justice Act, you cannot discriminate the students of the Republic of Kenya. You cannot push them money, go to help, and the Minister for Education is saying the money I have is not for KMTC. But I want to give this way forward. And now I'm hearing, a very important point, that even what they collect on behalf of KMTC, they should plow it back to KMTC. But this has been a very protected both litigation and government during President Uhuru Kenyatta. I am aware, and even this government. But before I go to the cabinet, and I start a cabinet memo, I really humbly ask this House, the two committees, to invite the Minister for National Treasury, to invite the Minister for Education, to invite me plus my KMT KMTC are suffering. So we must close it. And as we close it, give us the 680 million so that because the process will be a bit long, 1 month on cabinet. First give us the 680, but please, even if it is going to be, once you finish the budget, invite those three of us to this room so that I speak for KU. And before we come here, we will have a meeting, because we have a cabinet collective responsibility. So we might even come with an answer. Invite Honorable Bandi, invite Honorable Minister for Education, and invite me. We work for the people of Kenya. We don't work in silos.
Yes, we had the two. We had the Minister of Education. We'll add the other two. We'll have that meeting. This committee is keen to get that resolved once and for all.
And the admission of KMTC should revert back to KMTC.
The agenda will be
as per the court ruling. Yeah.
Let's implement the court ruling.
Yes, in the new mood. Let's hear you.
The only thing I'll say on Hansard,
yes,
is that KMTC must also, and the is here, it must do a fair, transparent, equitable
admission
recruitment of students.
and staff.
KMTC, before I came to the office, also there are quotas who claim it that people buy the admission letters. I want to go on record that it will never happen under my watch. It must be transparent, it must be equitable, it must be given to the right students based on their records. Why it went to COOPS, some people argue because the process was a bit flawed. But that cannot be a justification. I'm sure Dr. Kelly and his team will do the best they can.
Yes, you will know. Yes, let's have the...
Thank you very much, Chair. And in the new mood, we are all energized. First and foremost is to really express my gratitude for this committee granting us this opportunity to be here, and for always supporting this State Department. Chair and honorable members, this is part of your mandate, which is enumerated in the Constitution of Kenya, and we are always happy because the Constitution guarantees Kenyans and each and every person the right to the highest standards of health and available, affordable, acceptable, and accessible quality health care. And for this reason, the government has identified healthcare delivery as one of the core pillars of the bottom-up economic transformation agenda. the government again has embarked on the various interventions as listed in my statement. I do not want to go through word for word. Honorable Chair and committee members, turning to the budgetary allocation in regard to the proposed 2025-2026 draft estimates, the health sector has a total allocation of 136,785, and out of which 31,341 has been allocated to the State Department for Public Health and Professional Standards. And this, Chair and honorable members, translates to 22.91% of the sector allocation. We recognize the importance of investing in curative health.
We are on page 4.
Yes, page 4. We recognize the importance of investing in curative health. However, we also strongly believe that the greater emphasis and investment should be directed towards preventive health. And by reducing the burden of preventable diseases and empowering individuals to take charge of their well-being, we can establish a more sustainable and effective healthcare financing model for our country. Honorable Chair and committee members, having recognized this committee as a very important stakeholder in achieving our mandate and being cognizant of the current economic situation in the country, I will later on in my presentation make a request for your consideration to allocate an additional 22.71 billion to finance some key institutions and pragmatic areas that are either underfunded or not funded at all in the proposal. Our geographical positioning as a country, where we have influx of people from the other neighboring countries. And we have also had a surge in terms of public health events. We have had Mpox, Marburg, and other public health events that are also in the neighboring countries. We have disease surveillance, Kenya Health Professions Oversight Authority, the Kenya National Public Health Institute, the National Quality Control Laboratories, the National Public Health Laboratories, Food Safety, Neglected Tropical Diseases, and as you very well know, Chair and honorable members, we have an issue of Kalaza in the northern counties, clinical waste disposal systems, health promotion and education, which is very, very critical in regards to public health and education, and intergovernmental forums. Remember, health is a devolved function, and every time we have to meet with the other level of government, that is the county government, to agree on some issues, and especially when we are cascading down the policy implementation to the county level. Honorable Chair and members, the State Department comprises of several directorates and semi-autonomous government agencies, which I will not read word for word on page 4. We could go to page 6 of my presentation, where I'll touch on the organizational structure of the ministry and the State Department, where we have 4 technical directorates and an administration directorate and 20 semi-autonomous government agencies as outlined below. We first have the primary health care, whose mandate of the directorate is to formulate, oversee the implementation, monitor and review policy guidelines, standards and frameworks on preventive and promotive health services. prevention of communicable and non-communicable diseases, mental health and wellness, accidents and injuries, health education and promotion in collaboration with other relevant stakeholders. And this is composed of 9 divisions that are namely malaria control, management, drug control and substance, TB and other lung diseases, health promotion and education, health and wellness, community health, primary care networks, school health and nutrition dietetics. Then we have the Directorate of Public Health and Sanitation. The mandate of the Directorate of Public Health and Sanitation is to formulate, oversee implementation, monitor and review policies, guidelines, standards and frameworks pertaining to provision of public health and sanitation services in collaboration with other relevant stakeholders. And in that directorate, we have the surveillance, we have national emergency and preparedness, environmental health and sanitation, national laboratory services, and port health. Chair and honorable members, we also have the Directorate of Health Standards, Regulation and Quality Assurance, and the mandate of this directorate is to formulate, review and oversee implementation of policies on health standards, quality assurance and regulatory health services. And this is composed of 4 divisions that are namely health policy regulations, health standards and compliance, human resource and health and professional standards, and health sector monitoring and quality. And finally, we have the intergovernmental relations, that is the health sector coordination, whose mandate is basically to coordinate, engage, and the involvement of government ministries, agencies, departments, county governments, foreign governments, non-state actors, and stakeholders in the formulation, review, implementation, and monitoring of health-related policies, programs, and projects. We have 3 divisions in that, where we have health sector coordination, intergovernmental relations, and international health relations, and health sector research development. We also have the support system, which is the administration, and the functions of administration involve the development and maintenance of internal monitoring systems and procedures, as well as the creation of implementation of annual administrative work plans and programs. Equally, to oversee the planning and the budgeting of administrative functions that coordinate national government functions and implementation. On our semi-autonomous agencies, I would not wish to go through word for word, but just mention who, and they are here today. We have our KMTC, which is our premier mid-level training college. We have KENRA, the Kenya Nuclear Regulatory Authority, the Kenya Medical Practitioners and Dentists Council, the Kenya Human Health Resource Advisory Council, the Kenya Health Professions Oversight Authority, the Kenya Nursing Council of Kenya, the Clinical Officers Council, the Kenya Medical Laboratory Technicians Technologists Board, the Kenya Nutrition and Dietitians Institute, the Public Health Officers Technicians Council, the Pharmacy and Poisons Board, the Tobacco Control Board, the National Quality Control Laboratory, the Physiotherapy Council of Kenya, Health Records Information and Managers Board, the Counselors and Psychologists Board, the Kenya National Public Health Institute, the Kenya Hospital Authority Trust Fund, Occupation Therapy Council of Kenya, the Kenya Institute of Primate Research. For the financial year 2025-2026 and the medium-term budgets, Honorable Chair and committee members, allow me now to respond to the matters outlined in the invitation letter and the requested information which has been provided in the annexes of the presentation. And first is identification of any significant deviation between the budget estimates and the approved budget policy statement ceilings, the provisions for the bottom-up transformation agenda projects and value chains, the project information including start date, initial cost, cumulative expenditure, financing resources, completion status, and geographical location. With respect to new projects, Honorable Chair and members, information on project financing and feasibility, information on the current stock of pending bills and strategy for their resolution, any part and any other pertinent issues affecting the MDA. And Honorable Chair and members of the committee, the State Department of Public Health and Professional Standards intend to implement 4 programs and 12 sub-programs in the financial year 2025, 2026, and the medium term, which are as follows. The first one being the preventive and promotive health care, for us to have reduction of disease and to reduce the disease burden in our country due to preventable causes. Equally, program number 2, which is the health resource development and innovation for enhanced human resources for quality and healthcare. And I think my CS has elaborated that into details. The health policy standards and regulations, he's equally touched on the scope of practice and other regulations that we are bringing on board to ensure there is adherence to the law and equally ensure there is order in the Ministry of Health. And general administration, which is to bring efficiency in the governance and administration that must be strengthened. When we talk about issues to do with finance, issues to do with accounting, issues to do with audit that must be looked into through general administration of. And the sub-programs that we are looking at is the issue of communicable disease control, disease surveillance and response, public health services, radiation safety and nuclear security, and primary health care. And just to pick on one, which is the primary health care, Chair and honorable members, primary health care is our anchor to our achievement to the universal health coverage in this country. And you know that is the flagship project that we have in both in the Ministry of Health and the government through the bottom-up economic transformation agenda. So primary healthcare, the establishment of the primary healthcare networks, which is very critical in our referral system, and especially when we are talking about the social health authority, when we have to refer one patient from level 2 to level 3, then we will have to have the geographical mapping of the facilities from one area to the other. Therefore, and equally primary health care, the community health promoters who are really, really critical in our day-to-day. And if I may mention, Chair and honorable members, as at this morning, our community health promoters across the country have been able to see individuals moving from one household to the other. A figure of 29 million Kenyans, screening them for diabetes, and have been done, and out of these 340,000 people have been referred to a health facility for further testing and management. Again, the screening of hypertension, which is very, very critical and has disturbed many people in this country. And out of these, more than 600 people have been referred to a health facility nearby them. And of course, using the primary care networks, it makes it easier to identify which facility is near any patient and they will be attended to. And of course, when they have the social health authority, when they have registered to the social health authority, when they have paid up, they will be able to access the services that are being offered through SHA. 344 pregnant women have been identified in the communities, even in the far-end communities. And out of that, 134 have been referred or linked to a health facility. Remember, in SHA, we have the service for prenatal, during delivery, and postnatal services. Therefore, it is important and very critical when our community health promoters identify these pregnant women in our society and they are referred to the nearest facility for further assessment during pregnancy. And the other sub-programs, Chair and Honorable Members, which I can elaborate in terms of health resource and development, capacity building and training. We are already working on our postgraduate training to ensure that is streamlined, because most of the healthcare workers are coming from our counties, and that is another level of government. So we have to streamline and see how is the release for these healthcare workers from the county to the national level, and the payment that is made to these particular facilities. Research numbers don't lie. If we do not continually research on what requires to be done in this country in terms of healthcare, then we will have ourselves to blame. And as the leadership at the State Department of Public Health, we are taking this seriously and to another level to ensure that research and innovation in the health sector continues. Policy, standards and regulation. As you have seen, I have a long list of regulators in the State Department, and we continually want to have health standard quality assurance, health policy planning and financing of the same. And finally, the general administration, which I had earlier on talked about. Chair and Honorable Members, the analysis which I am going to give below of the proposed budgetary allocation of resources to the State Department at both recurrent and development level, as was submitted to the committee in the 2025 budget policy statement versus the proposed allocation of 2025-26 draft estimates. Therefore, the total gross budget for the State Department for 2025-26 financial year draft estimate is 31.342 billion, made up of 26 billion in recurrent vote and 5.1 billion in development vote, respectively. Chair and Honorable Members, as per the 2025 budget policy statement as submitted to this committee, the total gross budget for the State Department 2025-26 financial year was 31.3 billion, and that was made up of 26.3 billion in recurrent, kindly move to the table on page 14 that will give you a glimpse of the deviation in recurrent. We have the personal emolument, which is at 5.6, and the draft estimates at 5.8, having a positive deviation of 255 million. The operation and maintenance, 752 million, and we have the draft estimates at 924. We have a deviation of 172, which is positive. The transfers to the sagas, this is really where the rubber meets the road. And we can see the deviation is 547, meaning most of our sagas have budget cuts that have really affected the operations and the day-to-day running of these sagas. Remember, Chair and Honorable Members, this is a very new State Department, and we may not be able to support the sagas as is required if their own budgets are deducted. Then I will move to development vote and I want to pick on a few areas. We have the Special Global Fund grant for malaria, which has a negative deviation of 751. Chair and honorable members, since last year we have had the distribution of the long-lasting insecticidal nets across 24 high-risk counties in this country in regards to malaria. And as Medic, you very well know that the prevalence of malaria in this country is at 6%. So we still have not gone to 0% or at least 0.something% in regards to malaria. And if we do not enhance and push the fight against malaria in this country, then we will keep issues recurring and have our hospitals have the disease burden in our hospitals and across the households. Therefore, we request that we regularize this so that we are able to fight malaria in the country. Equally, there is the construction of the infrastructure upgrade of Kenya Institute of Primate Research. I know the agencies will have some time to speak about this, so I do not want to delve into the radioactive waste processing for KENRA, the Kenya Institute of Primate Research, and KMPDC Examination Center, which is already ongoing. Construction is ongoing. We have, we can move to the next page, page 15. Honorable Chair and members, the analysis of our proposed budgetary allocation of resources to the State Department at both program and sub-program level was submitted to this committee in the 2025 budget policy versus the proposed allocation of 2025-2026. And we can pick the deviation that is there in numbers. I know later on I'll give the we can see the deviation that is there. This is for the current budget. Yes. The deviation that is there for 2025-2026 budget. In the communicable disease prevention, we had a deviation of 902. In the program, the total program deviation had 2.08 billion. In program 2, we had a deviation of 4.378 billion. In program 3, we had a deviation of 4.46 billion. And in the final program, we have 2.17 billion deviation. Honorable Chair and members, the committee and members, from the above analysis, there is a small deviation between the budget estimates and the approved 2025 budget statement, ceiling totaling to 1.83. And some of these areas in the proposed draft estimates, but were not included in 2025 budget policy statements, is the issue of medical interns. I will not delve into that again because my CS has extensively elaborated on that matter. The matching fund from the national government for the community health promoters. Initially, Honorable Chair and members, we had kits and funds and for 100,000 community health promoters. However, there was a deviation of 7,831 who did not have kits and they did not have funds. Already the State Department has sourced for funds for the 7,831 kits for the community health promoters who may be working at the county level and do not receive stipends from the national government. Therefore, we would want that gap for the payment of the 7,831 CHPs that amounts to 3.234. Then the training for human resource for health at 203 million. The payment of medical doctors' basic salary arrears. Remember, as per the CBA, the medical doctors had salary arrears of 3.5 billion shillings, which the national government has already paid 1.75 to the county government, and we are remaining for the second year 1.75. Then the primary health care networks, as I have elaborated earlier, that the PCNs are very critical for the attainment of our referral system and structure. Honorable Chair and members, the State Department wishes to bring to the attention of this committee that there is a huge reduction in the budgetary allocation to the semi-autonomous agencies, deviating from the initial allocation which was presented before the committee 2025 budget policy statement as listed below. I will not go through because they have another chance to elaborate on it. But from
just clarify.
Yes.
The areas where you are saying medical instant, matching funds, training of human resource, payment of medical doctors' basic salaries, this is what you had proposed and not provided.
Yes.
On page 16?
Yes, on page 16. Medical interns, 4 billion, matching funds to pay stipends, training of human resource for health, the payment of medical doctors' basic salary. Some of the areas which have been funded in the proposed but were not included in the budget policy. What does that mean?
What I was explaining, Chair, sorry, maybe I can rephrase my statement.
Yes.
Is the areas that I have mentioned are some of the highlights that are in the table of the proposed 2025-2026 budget. Therefore, we already have this in the proposed budget draft. We have the medical interns, that is 4 billion. We have the matching funds, 3.2 for CHPs, and I was explaining that the additional is for the 7,831 that were never catered for before. And we have training for human resources, which is 203. Then we have the payment of medical doctors' basic salary, which is 1.7, and primary healthcare networks at 225. So it's already captured.
Proceed.
Thank you, Chair. So from the above, or from what I have already given, it can be seen that 1.095 billion has been reduced from the allocation to the SAGAs in the proposed budget draft estimates, and this is a deviation, Chair, from what was submitted in this committee in 2025 budget policy statement. Page 17.
When we talk of this internship, there is the controversy of 70,000 and 206. What are they budgeting with?
Thank you. May I proceed?
Proceed.
The National Treasury, in its circular of May this year, informed all ministries and agencies that during the finalization of the budget estimates of financial year 2025-2026, that it was directed by the Cabinet to implement the expenditure rationalization aimed at capping the fiscal deficit at not more than 4.5% of the gross domestic product for the year 2025-2026 and budget. And in the circular, it was proposed that allocations to current grants to government agencies and other levels of government be reduced by up to 20%. And the level of this proposed rationalization is way above 20%, Honorable Chair and Honorable Members. So this reduction is likely to affect the performance of the affected agencies and particularly on the payment of the personal emolument to the staff. Honorable Chair and committee members, I request that the intervention, I request for the intervention of this committee to reconsider this proposal and allocate resources to the aforementioned agencies and at the very least, Chair and honorable members, to enable them to pay their personal emolument for its staff. Chair and honorable members, we have had instances where our agencies delay salaries for even up to 5 months and more. It is additionally that I would want to urge this committee to reconsider reviewing funding allocated to the capital projects, particularly ones whose project implementation period is coming to an end. On the alignment of the statement, the estimates to the bottom-up economic transformation agenda, policies sector, where health sector is tasked with 4 areas: health commodities, security, including local manufacturing, human resources for health, health financing, integrated health management information system. And the key sectorial policies underlying the proposed 25-26 budget estimates, as highlighted on the paper, is 1, the preventive and promotive shift. The government's shift from curative to preventive and promotion health signals a significant policy change, and that is why we have the 107,831 community health promoters, improvement to screening, and even in SHA, we have components that are more preventive and promotive health. Integration of preventive services at primary healthcare levels that indicate a focus on early intervention and health promotion. From the electronic community health information system, Chair, I have simply just given you numbers of what we receive on a daily basis of what the community health promoters are doing. And we are on the verge to improve on the system, on the SIM, so that we could also tell where each community health promoter is at any given time. That when they visit a homestead, we actually can tell from the dashboard that community health promoter X has visited home X in this county, in this sub-county, in this ward, and in this village. Then and that I have already elaborated, the community health promoters and primary health care networks. I explained much earlier that the geographical mapping of our facilities is very critical to attainment of the available, affordable, acceptable, and accessible quality health care. From whenever a patient is, they should be able to tell which health facility is near them. If there is an emergency, they must be able to get to that facility in good time and record time. And we have human resources for health. In the alignment of functions to the ministries, the government came up with the unit for professional standards. And this was to ensure that human resources for health is not left behind anymore. And I am happy that through the leadership of my Waziri, the CS, he's been able to align a lot of things, starting from the scope of practice, something that never used to be there before. And Chair, when we talk about the community health promoters recruitment, collaborating with the county government to recruit and deploy the 107,831 community health promoters, a policy initiative aimed at strengthening community health level. I'll keep going back to the CHP because this is the backbone of and is our level one. Our level one. Therefore, emphasis on supervision, emphasis on refilling of commodities to the community health promoters is very, very critical. And as we continue replacing the worn out garments, because it would be very embarrassing when we have our community health promoters working with torn jackets out there way after we have already launched the program. And we have the digital health agenda, implementation of the electronic community health information system. And this, Honorable Chair and members, because we have our CHPs provided with the smartphones for data collection, demonstrates a commitment to utilization of technology for real-time, accurate, and health data. And this is going to be connected to our digital superhighway, which we are already implementing. And overall, the universal health coverage that emphasizes on the delivery of health coverage and suggests a policy commitment to ensure healthcare access for all citizens in this country. We are leaving no one behind. Honorable Chair and members, Honorable Chair and members, I want to skip the narrative on page 19 and pick on a specific note at 2.3. For project information, which includes the project starting date, initial cost, culminative expenditure, financing resources, as was stipulated in your letter, Honorable Chair and members. We have listed new project justification as is shown on page 20. And that which is touching on our agencies, I'll leave it so that we elaborate later when the agencies are presenting. We have Kipre that has the snake antivenom processing plant, which is considered a neglected tropical disease by the World Health Organization. Again, Chair, the state, if we move to the pending bills.
Here's what you can do.
Yes.
Under those ones, just state what it is and the amount of money you think it requires, and briefly, and we'll get the details if we get to the agencies.
Okay.
This is budget, so we will meet with some of these departments individually. Yes. To understand what they do. Yeah.
Yes.
We are on page 20.
Yes, we are on page 20. So the total project cost is 1.825 billion for the snake antivenom processing plant at Kipre, and that is to be implemented in 3 years, where each year will require a budgetary allocation of 608 million. For the pending bills, Chair.
You may also say, is there money for it now, or required for it and not there?
How much is it?
Yeah, so that's what we want to do. So if you say snake venom, is what money is for it there now? What money do we require and when? Then you go to all the others. quick.
Chair, I think you are very right. We need to talk about numbers. What was in the PPS, what is in the draft, and what we require.
Bas.
The differences.
It is here. It's on this page. What was in the DPS? was
On
100.
page 14,
You're taking us back to 14.
because that is where the information is.
Okay.
What was in the draft is 100.
I thought you were on a new list of new projects. They are here. They are on 14. Yeah, so what then you do? If they are there and they are here, then just mention them here, and then this we can read. And the agencies will then tell us.
That's why I was
that's what the
picking it
agencies
here.
will do. Okay. Then go to 14 and list 14 quickly. New ones.
We only have one new project to discuss.
Honorable Chair, we only have one new project and justification, which is Kipre, and I've already given
The
information.
anti-snake venom.
Yes, what
Fine.
is required, what is appropriated is 200 million.
Good.
So we require 408 million
Okay.
to make 608 for
Okay.
this, for the year.
Okay.
Then the State Department in the fourth quarter of 2024-2025, implementation of the appropriated budget, Chair, there is no pending bill already accrued, and any earlier highlighted in the opening remarks, the health sector total budget allocation is 136 billion, out of which 31 billion has been allocated to the State Department of Public Health and Professional Standards, and which translates to 22.9% of the whole healthcare, the sector allocation. So this has left a very huge budget, Chair, in which we are requesting for 22.7 billion in this budget allocation to cater for all the mandate as outlined in the Executive Order number 2 of 2023. I will ask you to move to page 32. That's the final page.
Yes, so you are submitting.
It's the last page.
The last page, so you are submitting. You are submitting now.
Honorable Chair and members, the State Department appreciates the fiscal framework may not allow the committee to fully fund the budget deficit. However, we request the indulgence of this committee to consider funding core program areas which have been highlighted above in the proposed draft estimates for the year 2025-2026 before the committee, in particular the huge budgetary cut to the semi-autonomous government agencies whose government support allocation has been completely removed. Chair and honorable members, as I conclude, let me say thank you. Thank you. Thank you to this honorable committee for the cooperation you have accorded to the State Department of Public Health and Professional Standards and your continued support to the State Department, which will ensure prudent financial management through the resources appropriated to finance the planned programs and activities in 2025-2026. I submit, Chair. Thank you.
Thank you, PS. I think now, before we go to the sagas, we'll open it, honorable members, and at this time we have two sets of areas we can ask. We can still get other areas of the CSS policy. I know we dealt with the KMTC and help a bit, but there are other areas that we require, and also the details that we may have on the PSS presentation. And both CS and PS take note so that we get a batch of questions, then they are done, and if you're done, we move to the sagas. So,
Chair.
colleagues, yes.
Just to add on two very important issues that one is we are implementing universal health care service, and we have developed a digital technology superhighway which has 38 systems, and this, from the dashboard you can tell. In the beginning, this digital health system of UHC will be paperless. Kenyans will not carry a SHA card the way they had the NHIF card. All they need is to carry their biometrics. This system is linked to the National Registration Bureau. It also has the Kenya Medical Practitioner and Dentist Council database of all the doctors. The same with the clinicians and all other healthcare workers, so that we can get rid of the quacks in the health care workforce. We will never have again in our country the characters like Dr. Mugo, the famous Dr. Mugo. It has something called track and trace in connection with Pharmacy and Poison Board. So the drug that is dispensed to the people of Kenya can be traced to the manufacturer. Our biggest problem here is we have two institutions here. We have the Kenya Medical Practitioners and Dentists Council, led by Dr. Kariuki, and then we have the Clinical Officers Council. These two institutions are the ones that license and regulate facilities. We pay every 14th day of the month. Yesterday, the day before yesterday, we closed 77 facilities in one county, private facilities. And he's here, we can share the information. He has downgraded 114 facilities in the same county, because some of them were saying they're at level 4 when they're not at level 4, they're at level 2 or level 3. Now, we have said we must re-evaluate all the facilities to get rid of ghost facilities, facilities that don't meet the required infrastructure, their sanitation is bad, facilities that have been colluded and have been formed because of insurance fraud. Now, these two institutions, their resources, for them to do inspection and registration of facilities, for them to do periodic inspection of these facilities, for them to do an audit of all the foreign trained health professionals in our country, because I have stopped no more foreign health workers to our country, because our people have no jobs, we are training more. So they must have resources to audit all foreign trained healthcare professionals working in our country today. They are supposed to report on all outstanding professional negligence. We have a very high maternal mortality rate in our country, and let me be very clear, there are a number of factors.
Before you leave that, Wazid, I don't want you to leave that, because in the morning I was complaining to the DG that in my county I have a private hospital that has a doctor from Nigeria here, who for the last 1 month has killed 4 women on the Sicilian table. So when you see they are not here, they have one in Chuka, I'm getting very worried, the Nigerian.
Okay. Yes, let me just say, and that's why I'm saying they are supposed to report on all outstanding professional negligence, be they Kenyan healthcare workers, be they foreigners, because the maternal mortality rate in our country, Honorable Chair and Members, Health Committee, is very high. Our neighboring countries are doing better. A mother going to deliver in a health facility is not a patient. She is a happy person, healthier. She walks happy. She wants to walk out more happier with her baby. But in most health facilities, we are being told a mother and the child dies. There was a county which had high levels between January and March. But when he sent a team, we found there was professional negligence. And we will go further with the help of this committee that if it is the professional negligence and the county in one way or the other, they don't deal with this doctor, then the regulator has the powers to cancel the license.
So CS.
So I'm saying their money has been reduced. We need to give them more money.
So what then we do? Because what I noticed is as we are going through this, you went through the list as our letter said, and so you listed everybody. Now we then didn't prioritize. We can quickly, as we are going through, if you have somebody, put down critical areas which you actually want better funding, the people who need more funding.
I have said that. One is KMTC,
okay, the
690.
Yes.
We just want some more funding for the regulators,
okay,
to make sure that we enforce and we deal with the help in both the facilities regulation and the doctors regulation. We need some money for the operationalization of the National Public Health Institute, and we need, of course, the two regulators, Clinical Council and the KMPDC. I think those are the critical ones.
Okay, yes. So I think that is that. Let's come back to the format we were.
Yes, now we're okay.
Yes. Can I? Yes, start Honorable Sunkuli, then Honorable Wino, and then I know how we'll go.
As you know, mine is very short. I mean, I want to ask the minister, because he wants more money for the regulators, and I hope that he's also now contributing to the policy change in the government that seem to have said that they are going to be merged. So how will declassified? So I don't know how that will be, whether that will not be in contradiction.
I think the story of merger and rationalization of...
See, so that we go, I know how, if we start one by one, it will be very long. So take note, that's a very important question. You are asking for more money for regulators, there's a policy saying you want to merge them, and some not. So that is the question. So put mark of that. Honorable Malende.
Chair, I wanted to pick that up. There is CS, you cannot talk from both sides of your mouth. We have the cabinet decision that included the same regulators, including winning them of exchequer funding. It was a cabinet decision that was made public. And then you're here asking for funding from Parliament for the same bodies. So that is where I see. Okay. So that's number one. See as the second one. When you talked about the payroll for community for the UHC staff, you said you're sending it back to the counties because they work in counties. We have the stipend for community health promoters, the contribution sitting also at the headquarters, and they are working in counties. Again, how does that relate in terms of uniformity of policy? The other area for me is the digital superhighway, touted at 104 billion. And then here I come and find a standalone issues for community health promoters. We thought the superhighway should coherently coordinate everything digital in the ministry across board. So again, we begin to question the 38 modules that you say that this highway has. Then lastly, community health. During the presentation, and here I'm sure the DG will remember, we had a section on health systems reengineering, and it also talks of patient flow, patient limited experience. Then on the other side, we are having community health networks that are supposed to be in the referral system. Isn't then the referral system a part of medical, State Department for Medical? Is there overlap there? Yeah, I think Cheske PDC has a problem. This regulator examines foreign doctors, and currently they are examining, I think, 11 or 12 dentists. Out of those dentists that are sitting the exams, 3 of them did not meet the minimum academic qualifications needs to be re-examined, because a lot of the problems we are having are actually emanating from